The transoral Transpalatopharyngeal approach for ventral decompression of the medulla is now going to be described. We will first start with the operative setup. The transoral exposure gives access to the inferior third of the clivus down to the C3 vertebral body. Higher exposure requires splitting the hard and the soft palate. An awake fiber optic oral endotracheal intubation is performed first with the cervical collar in place. Following this, general endotracheal and intravenous anesthesia is ensued. A crown halo is placed at the equator of the cranium and traction is utilized with about 7 pounds. The head is positioned on a Mayfield horseshoe headrest and traction is applied. The patient is secured to the operating table. The neurosurgeon stands at the head of the operating table and faces downward. The endotracheal tube is secured to the skin at the mid portion of the mandible on the left so as to allow for access by the anesthesia service. We need to consider this as being a sterile procedure and hence the preparation of the circumoral region. The setup is visualized. Q-tips dipped in 4% cocaine anesthetize and shrink the nasal mucosa and the turbinates, which is then followed by cottonoid pledges soaked in cocaine. A throat pack is used to occlude the laryngopharynx to prevent blood and irrigation from going into the trachea. A sterile preparation is then made of the circumoral region. The oral cavity and pharynx are cleansed with successive rinses of 10% PVP iodine, followed by saline and then hydrogen peroxide. This is one of the most important steps of the operative procedure. The cottonoid pledgets in the nostrils are visualized. The final head position is seen. The right anterior abdominal wall is prepared for possible harvesting of the external oblique aponeurosis and fat, should this be required if the dura has been transgressed. Stay sutures are placed on either side of the uvula at the edge of the soft palate. The midline raphe of the soft palate is infiltrated with 0.5% xylocaine with 1 to 200,000 epinephrine. The midline soft palate incision starts at the base of the uvula and immediately ascends in the midline raphe and is continued towards the hard palate, depending on the amount of exposure that is required. Stay sutures are used for lateral retraction of the leaves of the soft palate to expose the high nasopharynx. An angled Colorado needle provides sharp dissection as well as a bloodless field.